Good afternoon, everyone. Good afternoon, sir. Good afternoon. Today we are going to discuss about development of cardiovascular system and their clinical correlation. So our objectives are, initially we will discuss about development of heart and then vascular system and conduction system. In development of heart, for the convenience sake, I have divided into two parts: early development, where the formation of structures happen, and the late development, the modifications of already formed structures. So it starts around day 16 in the third week, and by fourth week early development will be completed, and after that late development will happen. So a brief introduction. The heart is the first functional organ to develop, and it appears in the middle of the third week, and even it begins to beat by day 22. And through ultrasound Doppler we can visualize it by end of fourth week, that is 6 weeks POG. In like embryology terms, it is by the end of fourth week we can visualize the ultrasound Doppler. So before third week, how the cells get nourishment? Like, can anyone guess?
Before post-fertilization is the
post-fertilization
by glutoplasm, cytoplasm of the bone.
Yes, sir.
By dona pellucida.
Yes.
Next by blastocyst in the uterine milk.
Yes.
Uterine cavity.
Yes, sir.
Then after implantation, intestinal stroma.
Yes, sir.
Then by uteroplastic circulation, primitive syncytial lactinate.
Yes.
After lactinate, through uteroplastic circulation by primary dilatation.
Yes, sir.
This is the main part of nourishment.
Yes, sir.
But there are additional ways of base of nourishment.
Okay, sir.
Apart from these ways, there are additional ways.
From
They are through simple diffusion.
Yes, sir.
In the first 2 weeks, by simple diffusion through external embryonic coelom, primary, secondary yolk cells. There will be simple diffusion.
Simple diffusion. Yes, sir.
So there will be accumulation of fluid in the yolk sac and intra-embryonic coelom. To clear the extra fluid in the yolk sac and intra-embryonic coelom, this peristaltic movement starts.
Yes. Before third week, just simple diffusion, cells get nourishment. But due to the rapid growth of embryo, the simple diffusion cannot maintain the nourishment. So we have the development of heart, and it begins by third week itself for the nourishment of the embryo. Our like first we have to establish the heart field, then laterality. So the progenitor heart cells will lie in the epiblast immediately adjacent to the cranial end of the primitive streak. So from there they migrate to the visceral layer of the lateral plate mesoderm. In the next slide we will see the primary heart field, which gives atria and left ventricle, whereas your secondary heart field we'll discuss in the further slide, which gives the outflow tract and your right ventricle. So here the primary heart field forms the cardiac myoblasts, and your blood island forms the blood cells and vessels. At this stage your heart tube is two layered, only like endothelial lining and myoblasts are there. So here you can see here from the adjacent to the primitive streak in the epiblast there are cardiac progenitor cells. From there it migrates to the lateral plate mesoderm. This is paraxial mesoderm, this is intermediate mesoderm, this is lateral plate mesoderm. Here in the lateral plate mesoderm the primary heart fields are migrated, above which we have intraembryonic cavity. This forms your pericardium. So this primary heart field will be in a shape of horseshoe shaped. These blood islands and primary heart field, they later coalesce to form your primary heart field. In the initial stage your primary heart field is almost like anterior most part, anterior to the neural and your pharynx. It is the anterior most structure. So why it is formed in horseshoe shaped? Here it requires several transcription factors. Your BMP214 and NKX2.5, these are the stimulants for development of heart, whereas WNT is inhibitor. So inhibitor of inhibitor, again crescent will be the stimulant. So almost all three present in a horseshoe shaped. So that's why your progenitor cells will migrate and will be in the lateral plate mesoderm to form a horseshoe shaped structure. So we established a heart field. Now we have to see the laterality, that is heterotaxy. So heterotaxy, it is important for gastrulation and also for the development of normal heart. Here what happens is, on the left side we have more serotonin, 5-HT. So which transcript to the MAT3 receptors, and the master gene for left side is PTEX2. Because of this your heart and gas relation, everything will develop towards the left side. So clinically, if a patient is on selective serotonin reuptake inhibitor, so that's why this 5-HT will be decreased in concentration. At this stage, they will be having more heart defects. For example, if a patient has like serotonin on the right side, they will be developing dextrocardia. The patient with dextrocardia, their offspring will have more defects than themselves. That is one more correlation for laterality. So here we have established laterality. Now we have to see how the heart tube is formed. Initially, there will be two heart tubes, like horseshoe shape, but when you cut section, we will have a paired heart tube. So the position, initially it will be the most anterior to the oropharyngeal membrane and to the neural plate. But because of rapid growth of the CNS through closure of the neural tube and rapid development of the brain vesicles, cephalic folding happens. So because of which your heart tube will migrate to cervical and then final to the thorax region. So because of the cephalic folding. So this is another representation. Here your cephalic folding happens and heart will migrate from anterior most structure to the thoracic region. Simultaneously your pericardium also will become your ventral side. Pericardium will become ventral side. So along with ventral folding, cephalocaudal, we will have lateral folding. Here if you observe lateral folding, the caudal region of the paired heart tube will merge. So here caudal most region of the heart tube will merge, except at the distal end. They form the your inlet tract, and the cranial part will not merge, will expand. So and it divides to form your outflow tract. This expands to form your future outflow tract. And also heart tube will bulge into the pericardial cavity. So here initially it will be like this, but later it bulges into the pericardial cavity, which leaves some folds here, dorsal folds, which later forms fibrous tissue known as dorsal mesocardium. In future, this dorsal mesocardium will disappear to form transverse pericardial sinus. So this is folding. And one more thing is development of secondary heart field will happen at this stage. This is a pharyngeal mesoderm. From that, your cells will migrate to the dorsal mesocardium to develop secondary heart field. This secondary heart field will help in development of your right ventricle and outflow tract. Your truncus arteriosus, bulbus cordis, all these parts will come from your secondary heart field. So at this stage, simultaneously, the myocardium, the second layer, will secrete cells, hyaluronic acid rich extracellular matrix between the endocardium and myocardium. That is known as cardiac jelly. From that cardiac jelly, cells will migrate to outer side to form epicardium. So at this stage, the heart tube will be three layered: epicardium, myocardium and endocardium. So this is the heart tube, the representation, like at the caudal end we have sinus venosus, primitive atrium, ventricle, bulbus cordis and truncus arteriosus. It will like form constrictions and dilatations, constriction, atrioventricular like constriction. This is bulboventricular constriction. We'll see the future of fate of this for better understanding. Your sinus venosus body will form your right atrium, like absorbed into the right atrium. Your atrium will form common atrium, which they again divided into right and left atria. A rough part will be formed from this. This is ventricle, it forms your primitive left ventricle. This is bulbus cordis, we can divide into three: proximal 1/3, middle 1/3, distal 1/3. Proximal 1/3 will form your primitive right ventricle. These two are your rough part. This middle 1/3, it is also conus, it forms your outflow tract of right and left ventricles. This is smooth part, and then this is truncus arteriosus, it forms your ascending aorta and pulmonary trunk. So clinical correlation, if this lengthening is not happened, so that secondary heart field lengthening is not happened, then there will be defects in your outflow tract. So there can be double outlet right ventricle, pulmonary atresia, stenosis, tetralogy of Fallot. These all can happen at this stage. So these we'll discuss in further slides also. So after lengthening, now formation of cardiac looping. This outflow tract will lengthen faster. So because of which the cranial end will bend caudally, ventrally and towards right, whereas your caudal end will bend upwards, like dorsally, cranial and to the left. So you can appreciate here. Here even you can see atrium is extra pericardial. Because of this cardiac looping, your atrium will become intrapericardial cavity, like within the pericardium. So this is how your cardiac looping happens. It is around day 23 to day 28, around 4th week of gestation. And then this conotrungus will be on your right side, predominantly like on the right side. But once atria enters here and then it develops transverse dilatations, the conus truncus will come in medial position. See here the conus truncus will become your central part. Initially it will be on right side, but it will become central part. This is atrium, primitive right atrium. This is left ventricle and this is right ventricle. So this is how normal looping happens. Here from atria to ventricle, we have it only enters to the left ventricle through interventricular foramen, like AV canal. From left ventricle to right ventricle through interventricular foramen. From right ventricle it enters to the conus cordis. Like there won't be connection between the right atrium and right ventricle at this stage. So only from right atrium to left atrium, from left atrium to here left ventricle, from left ventricle to right ventricle, and then this happens. This is normal looping. So what happens if it can rotate in the this is called as dextral looping. Sometimes looping can happen in the leftward direction. It is called as levo looping. So here levo looping happens. Here what happens is your left atrium will give to right ventricle and right ventricle will give to your pulmonary trunk. Same simultaneously here. Right atrium will give to left ventricle and then left ventricle to the aorta. So this is known as LTGA. Here also there will be rotation and here also there will be rotation. This is also called as ventricular inversion. So once the structures are formed, now we will discuss what is late development. Like we will see how the cardiac septa are formed in different areas like atrium, AV canal, in the ventricles, truncus arteriosus, all this. And also we will see the formation of valves. So septum can form in two manners. One, they can form actively growing tissues on the opposite side and can fuse. Or septum can form from the one side and completely go to the opposite side of the lumen. In these two manners, the septum can be formed. In this method, like endocardial cushions and your aorticopulmonary septum at conotrungus, they form like this, like two opposite side, there will be active growing tissues and fuse each other. And in this manner, ASD and your VSD will be formed, like atrial septum and ventricular septum will be formed. So we'll see how the septum formed in common atrium. Initially, there will be crescent-shaped, sickle-shaped growths from the roof of the common atrium. Here, the lateral parts will grow faster than the central part. So lateral part will fuse with the endocardial fusions, leaving a foramen primum or ostium primum. From this, blood transfers from the right atrium to the left atrium. So after like some time, even this also closes, and by the meantime, there will be perforations in the septum primum. This is called as this perforation will coalesce to form your ostium secundum or foramen secundum. So here it is foramen primum or ostium primum, here ostium secundum. Then after some time, because of the fusion of the sinus venosus, because there will be formation of next slide. Because of the fusion of the sinus venosus, there will be formation of septum secundum. Because of the rapid growth of sinus venosus and fuses with the right atrium, there will be formation of septum secundum. It also grows in a like crescent way. Here leaves one like foramen. This is known as foramen ovale. So by the time foramen ovale is formed, here the septum primum upper part is degenerated, leaves a oblique passage. It is known as valve of foramen ovale. We'll see in an animated video. So how it is formed. So septum primum is formed in a like in crescent shape. Lateral part is grown faster than the central part, leaving ostium primum. Then it perforates by a process known as apoptosis and gives ostium secundum. Then because of sinus venosus incorporating, there will be septum secundum is formed, which leaves a oblique passage known as foramen of ovale. Later after birth, because of decrease in pulmonary vascular resistance, there will be like an increase in SVR, foramen ovale is closed. If it is open, then it is known as patent foramen ovale. So now this is the right atrium, left atrium. Right atrium, as I said previously, the rough part is formed by the primitive atrium in both sides. In right atrium, smooth part is formed by the sinus venosus. In the left side, it is formed by the resorption of pulmonary vein. Here you can see only single pulmonary vein is there and then branches are there. But with the time, it resorbs into the left atrium. See here, rough part is replaced by the smooth part of the pulmonary vein. So, and then finally, all 4 branches will be opened into the left atrium. So, this is how pulmonary vein, like 4 pulmonary veins form your posterior surface or smooth part of your left atrium. So, clinical correlation. So, your septum can be divided unequally, or sometimes septum will not be formed at all, or what can happen, septum can be like incorrect or formation or resorption can happen, or sometimes septum can be closed prematurely. So, we will see what happens. So, if it is unequally divided, so left side will be like hypoplastic left heart syndrome can happen because of unequal division. So, left side will be less and right side will be more, or opposite, like right side will be less and left side will be developed more. So, hypoplastic left heart syndrome and hypoplastic right heart syndrome. Sometimes there won't be any formation at all. So, that is known as common atrium. There will be only 3, that is known as quad trilocular biventricle. Only 3 chambers are there, out of which 2 ventricles and 1 atrium. And incorrect formation or resorption can lead to ASD multiple types. And one more thing is premature closure. Before birth itself, your ASD will be like foramen ovale will be closed, because of which there will be massive hypertrophy on the right side, which so after birth there will be death shortly. So, here we will see different types of ASD. Here this is normal. Here excessive resorption of septum primum, which lead to septum secundum time of ASD. Here there is no septum secundum, so which lead to septum primum time of ASD. Here no formation of atrial septum at all. So, here common atrium or quad trilocular biventricle. So, now let us go to, after atrium, now let us go to AV canal, atrioventricular canal. Here initially there will be 4 AV endocardial cushion appears, one on right side, left side, superior and inferior. But these superior endocardial and inferior endocardial cushions will grow faster and fuse to form right AV canal and left AV canal. See here, at that time what happens is your AV canal also will grow more to the right side because of left to right shunting in the right ventricle will grow faster. Your AV canal will grow like more to the right side. So, at this stage there will be entry from the right atrium to right ventricle, left atrium to left ventricle. So, this is how intraventricular foramen will like connect from the right to right and left to left. So, after endocardial cushions there will be some thickening dense mesenchymal tissue at the end. Because of bloodstream from the atrium to ventricle, these mesenchymal tissue will grow into the or will hollows out into the ventricle to form AV walls, atrioventricular walls. In the left side it is bicuspid, whereas in right side tricuspid. These walls attach to the ventricle with the help of muscular tissue, which later degenerate to form chorda tendineae and which attaches with the papillary muscle. So, this is how AV walls are formed. Now, we will correlate clinically, like what can happen. AV canal, it can persist, like there may not be division in the AV canal, or sometimes partial defects of endocardial cushions can happen. So, in AV canal, if there is persistent AV canal, there will be only single atrioventricular canal. It is known as endocardial cushion defect. So, when you see in the ultrasound also, in like early fetal echo, there won't be any cross appearance here in the fetal echo. So, partial defect, endocardial will help in development of ostium primum and even membranous part of ventricular septum. So, this can lead to ostium primum ASD and membranous part of ventricular septal defect. So, regarding walls, the walls can be fused or there can be abnormal position of the wall. If the walls are fused, it will form tricuspid atresia. If there is abnormal position, that is your valve is displaced to the apex, or it is also known as like atrialization of the left ventricle, atrialization of the right ventricle. This is known as Epstein's anomaly. So, now let us see how septum is formed in ventricles. The ventricular septum will have 2 parts, thick muscular part and thin membranous part. Your thick muscular part is formed because of your expanding ventricles will merge medially to form like this thick muscular part, but these two will not merge completely, leading to interventricular foramen at the opening. Later, after some time, with the help of endocardial cushions, conus septum and muscular part of IVS, this also will close by means of membranous part. So different defects we can see, like ventricular septal defect. This is muscular VSD. Here perimembranous. Here outlet is there. So outlet type. Here inlet. From atria the blood will flow. So inlet type of VSD. And multiple muscular VSD, also known as Swiss cheese pattern or trabecular VSD, can be there. So now let us see how septum formation in truncus arteriosus and conus cordis. Here this is like a complex procedure. Here what happens is, in first truncus, right superior and left inferior wall, there will be ridges will appear on the opposite side. As I said, in the endocardial and this one, there will be opposite side ridges will be happening. This right superior will grow towards the left, right superior will go towards the left, and this left one will go towards the right. So twisting it, twist spirally. This is in the truncus. Simultaneously in conus also, there will be formation of ridges in the right dorsal and left ventral walls. They also will grow spirally and fuses with the septum in the truncus. So it will twist like 180 degrees spirally. Here if you observe, from right ventricle, blood, the outflow tract will go towards the left side to the pulmonary trunk. From left ventricle, outflow tract will go towards the right side aorta. So this is how your septum forms in truncus arteriosus and conus cordis. Here you can see from aorta it will go pulmonary trunk, and from aorta it will come from this side. So clinical correlation. So your septum formation cannot happen at all, or sometimes what happens, instead of spirally, it can rotate, it can divide in come without spirally, or sometimes what happens is unequal division of the septum. So these all three scenarios can happen. If there is no formation of aorticopulmonary septum, it leads to persistent truncus arteriosus. Both aorta and pulmonary trunk will come from the same artery. This is known as persistent truncus arteriosus, and that can happen like abnormal division. So because of which there will be transposition of the great arteries. Here your right ventricle gives to aorta and left ventricle will give to pulmonary trunk. This is a parallel circulation, two parallel circulation. So for which for the life to sustain, there should be either ASD or VSD or PDA should be present. Otherwise life will not be sustained, as it is a parallel circulation. And sometimes what happen is unequal division. Like your aorta will get more part and pulmonary trunk will be getting less part. Here what happens is the pulmonary part will develop pulmonary stenosis, right ventricular hypertrophy, overriding of aorta to the right side also, and there will be VSD. These four combinedly known as tetralogy of Fallot. And since these all growing happens from the neural crest cells, so from the neural crest cells they all get the cells. So if any thing happens in the neural crest cells, then we have certain sequence like Dyke-George sequence. There will be multiple anomalies will be present, like cardiac, anal and thoracic vertebral abnormalities. These all will be present. So it is a heterogeneous development. Any defect happens can lead to multiple defects. So now let us see how semilunar valves are developed. Here they appear in first initially one pair is formed in aortic and pulmonary channel, like small tubercles. Then one more third tubercle is formed in the both channel opposite to each other. So these all will later develop into semilunar valves. For this also neural crest cells will be contributing it. So here what can happen clinically, like there can be stenosis, like aortic valvular stenosis and pulmonary valvular stenosis. And this is one more clinical entity. It is a very rare anomaly because of failure of closure of the embryo ventrally. So which lead to ectopia cordis. Your heart will be outside the outside your ribs. So this is ectopia cordis. So this is how heart is developed, and we have seen all the clinical conditions related to it. Now we will see how vascular system is developed. So for the vascular system to develop, there will be majorly two processes. One, the new vessel should be formed, that is known as vasculogenesis by coalescence of angioblast, and another thing is angiogenesis. Here already existing vessels will sprout out into a new vessels. So your dorsal aorta and cardinal veins will form through vasculogenesis, remaining all will be your angiogenesis. So first we will see the arterial system. We have three major arteries like aortic arches, vital and umbilical arteries and coronary arteries. Now we will see aortic arches. So a brief introduction. Your aortic arches, they are formed like in the pharyngeal arches during development of 4th and 5th week. They arise, all the 6 arise from the aortic sac. They then embed in the pharyngeal mesochome and then terminate in the dorsal aorta. This is your dorsal aorta. Everything will form from the aortic sac, then embed in the pharyngeal mesochome and terminate into the dorsal aorta. So they appear in sequence of cranium to caudal. So first one appears first, then second, then fourth, then sixth. So by the time sixth appears, your first one and second one will be obliterated itself. So they won't be present simultaneously, but in a sequence. So total 5 pairs are there, 1, 2, 3, 4 and 5, and fifth one is not formed at all, or sometimes it is formed and then obliterated, then sixth arch. Your 1 and 2 forms there will be remnants only. Your 3 and 4 will form aortic arch of aorta, and your sixth one will form pulmonary artery. So your first arch artery will form maxillary artery, second arch stapedial and hyoid artery, only certain parts are remain, and your third and fourth will form your arch of aorta and its branches. So this is the third arch artery, we will see in the image. So this is the third and fourth. So here third arch artery, on the both sides it forms common carotid artery from the proximal part. From the distal part it will form internal carotid artery, which later joins with the dorsal aorta. So this is the fate of third arch. So first initially common carotid, then internal carotid, and then external carotid artery is formed because of the sprouting from the third arch. It is not directly linked to third arch, just because of sprouting it is formed. And now let us, this on both sides it is same. Now let us see on fourth. On the right side it only forms the right subclavian artery. So here is your right subclavian artery, and then which joins with the proximal part of the your dorsal aorta and joins with the 7th intersegmental artery. And then on the left side it forms the arch of aorta, and then which joins with the dorsal aorta, and here it forms your left subclavian artery. So there are many changes will happen. One, if you observe here common carotid and subclavian artery, there will be like much distance is there, but with time it will regress and it will like come here. And simultaneously see, even you can see vagus nerve, it will be coil, since there will be disappearance of the fourth arch on the right side, it will go up to here until the branching of your right subclavian and your common carotid artery. But here it is coiled at your ligamentum teres. So that is the fate of arch of aortas. Now we will discuss about vitelline arteries and umbilical arteries. This is your vitelline artery. In future they form your celiac and superior mesenteric artery. And your umbilical artery, this is the umbilical artery. Proximal part will form internal iliac and superior vesicle. Distal part will obliterate. And coronary arteries, they arise from your aorta. If at all they arise from the pulmonary trunk, it is known as ALCAPA, like anomalous origin of your coronary artery from pulmonary trunk. So they form by invading the aorta from the epicardium. They are derived from the epicardium. So this is the arteries. So certain defects we will see. So this is persistence of ductus arteriosus. So as the left side they will have more pressure, from left to right shunting will happen. So because of which there will be pulmonary congestion, and the child or baby will have tachypnea and all. So if this defect is large and significant, we have to close by ligation or button closure, device closure. If the small, we can leave. And sometimes what happens is there will be persistence of the door. This one will obliterate and this one will form your subclavian artery. But what happens is persistence of portion of right dorsal artery, aorta. So this lead to double aortic arch. So it forms a vascular sling. So because of which there will be compression of trachea and esophagus. So patient will be having dyspnea and dysphagia. So symptoms will be there. And there can be anomalous origin of right subclavian artery. Normally it appears from the this like proximal part, but sometimes what happens is from the dorsal aorta it comes from this side. So it comes from this side to this side, from left side to the right side, compressing trachea and esophagus, but it won't be forming any vascular ring or sling. So the symptoms will be very minor, only rarely they will be having symptoms. And sometimes there can be because of tunica media or intima proliferations, there can be coarctation of aorta. Based on the location, it can be preductal or this is ductus, so postductal. So they will be having upper limbs, they will be having more blood pressure than the lower limbs. And the interrupted aortic arch, this is because of abnormal regression patterns of the fourth arch artery. There will be, based on the regression at what place, there will be three types, type A, B and C. So here between the left subclavian, regression will be between left subclavian and descending aorta. Here left common carotid and left subclavian. Here between right common and left common carotid. So here this side they will receive oxygenated blood, here they will receive mixed mixed blood. So this is the type B, is the most common interrupted aortic arch. So in upper there will be no clubbing, in lower limbs there will be clubbing, differential clubbing will be there. So now we will see how venous system is formed. So here there are two things to remember. First, initially there will be right and left side venous system will be there, but the right side will the left side will regress and anastomose with the right side. So that is these two things we should remember. So in all the steps these two steps will happen. So first, sinus venosus, there will be vitelline vein, umbilical vein, cardinal vein, but on the right side on the right side they will regress. On the left side they will regress and then join to the right side. So this is superior, it forms superior vena cava and inferior vena cava. This forms your coronary sinus and drains the left oblique vein of left atrium. Same, left side obliterates and your right side forms merges with the smooth part of right atrium. So vitelline veins, this also before entering the sinus venosus they will be forming plexus around the duodenum. This plexus will regress at some part, will form the portal vein, and after just before entering the septum transversum, your liver cords also will grow into the septum and interrupt the course of veins and form successive vascular network known as hepatic sinusoids. We'll see in the image. So this is your vitelline veins. So here around the duodenum it forms a plexus. Here at some part they regress and form your portal vein. It drains superior mesenteric and splenic vein, and your liver buds also they will proliferate and form extensive vascular network known as hepatic sinusoids. This is the fate of your vitelline veins, and your proximal part will be closed and will of the left side will be closed and then will join into this one directly, it will form the inferior vena cava, hepaticocaudal part. So your umbilical veins, they will be initially present on both sides. On the right side it completely regress. On the left side it is present because it carries the blood from placenta to the liver. Once the placental circulation is increased, there will be direct communication will be present between left umbilical vein and the right hepaticocardiac channel. Here you can appreciate there will be, this is the left umbilical vein which is left. Once the circulation is increased, it forms a direct channel known as ductus venosus, which bypasses the liver into the inferior vena cava. So this also in after birth will regress to ligamentum venosum, and this is ligamentum hepatis, ligamentum teres hepatis. So cardinal vein, they are the major venous drainage of the embryo. So initially there will be two veins, anterior and posterior. Anterior cardinal vein will form your cervical part, and posterior cardinal vein will drain from the rest of the embryo. But by 5th and 6th week, there will be additional cardinal veins are developed. Your subcardinal, supracardinal and sacrocardinal veins, they take over the posterior cardinal vein function. So here also there will be anastomosis on the both sides. I'll show in the image directly. So this is anterior cardinal vein. Here anastomosis is formed between the right and left side. This is left bronchocephalic vein, then it regresses. So this is superior vena cava. Now we'll see supracardinal vein. Here also there will be anastomosis. Here it drains on the right side, it drains from the 4th to 11th. It is azygous vein. It forms hemiazygous vein. In the subcardinal vein, it drains blood from the kidney and also from the gonad. Initially they are lumbar structures, but it later descends. So same, it also forms your anastomosis and then regresses on the left side. This anastomosis is left renal vein. Then sacrocardinal vein. It drains from the blood from the lower limbs. Here on the left side, it again forms anastomosis known as left common iliac vein, and then on the left side it regresses completely. So there will be first initial on right and left side, then the left side will be regressed. Only the right side will be present. So we'll see what are the defects can happen. So there can be two, the left superior vena cava can be present. It drains to the coronary sinus and then to the right atrium. Or sometimes there can be two superior vena cava which drains into the coronary sinus and then to the superior vena cava. This is about superior vena cava. Now inferior vena cava. There can be double inferior vena cava or absent inferior vena cava at all. It can directly drain blood into the superior vena cava. So these are the defects in the venous system. And then conduction system. Before 21 days of gestation, all myocardial cells can have a pacemaker activity, but soon the pacemaker will be taken over by the cardiac tube and the caudal part, later by the sinus venosus, which develop into sinoatrial node. It will have supply from the sympathetic and parasympathetic nerve fibers, so by which it regulates your heart rates. So this is about sinoatrial node. Then AV node. AV node, it is formed because of transcription factor TBX3, which inhibits the differentiation of primary myocytes to ventricular muscle cells. It inhibits the formation of muscle cells, so they form your conduction system like nodes, bundle branches, and then Purkinje fibers. So impulse will transfer from the AV node to all this like Purkinje fibers and all. So this is conduction system. So and then finally last slide, your circulation before birth and after birth. Here before birth your blood enters from the umbilicus vein to the inferior vena cava. Inferior vena cava, it bypasses through the foramen ovale to the left side, and then from left side left ventricle to the aorta. In between there will be anastomosis like ductus arteriosus, and here foramen of this foramen of ovale. These all connections will be there. So your maximum oxygenated blood is to the liver, and then your upper brain and your heart, coronary arteries. These two areas there will be maximum oxygenated blood will be there, which supports your development of brain and heart. But once soon after birth, once we clamp the umbilical cord, there will be elevated systemic venous resistance and decrease in pulmonary resistance after breathing. So because of which there will be elevated, there will be decreased right side pressure, and so because of which there will be closure of the foramen ovale. So then your blood from the right side will enter right ventricle to pulmonary trunk. Here maximum circulation will happen, and then oxygenation will happen. From there it will return to pulmonary veins, left ventricle, aorta, and to here. So the changes will be foramen ovale will be closed. Here ductus venosus will be closer to ligamentum venosum, and this ductus arteriosus, this also will closer to ligamentum arteriosum. And these all umbilical artery will form your median umbilical ligaments, and then umbilical vein will form your ligamentum teres hepatis and all. So references. Thanks.